Good morning, good morning, good morning. I am excited and honored to be here, and I want to thank the CannMed 2024 crew for all their work in putting on this wonderful event. And what a wealth of information that we've received these past few days. I'm really, really overwhelmed, so thank you all very much. Now, if somebody will tell me how to work these things. We should have been oriented. I see it. There we go. Good. Thank you. I have no financial commitments, conflicts to declare. And the objectives of my talk, the talk is entitled Cannabis and Endometriosis, a Potential Treatment. I will describe endometriosis and its clinical picture. We'll look at its etiology and the current treatment options. Then we'll examine how cannabis seems uniquely suited to treat the many aspects of endometriosis and may be a promising treatment. I do have a case study, and I hope that I can get to it. I'm going to really go through this quickly. One more item, we no longer live in a binary world. My intent is to use inclusive language, though, yes, I might slip up, but when describing research findings, this discussion will use the gender terminology in the research that the researchers used. So, what is endometriosis? Endometriosis is defined as the presence of functioning endometrial-like tissue outside of the uterus. Normally, the lining of the uterus is where the endometrial tissue is, but when it's displaced or mislocated, it is called endometriosis. And it's also accompanied with a chronic inflammatory reaction. Now, the prevalence of endometriosis is about 10 to 15%. In the US, about 6.5 million women alone have endometriosis. The economic burden is impactful. It exceeds $22 billion in the US alone. And when you look at it compared to diabetes, it is more costly than diabetes. True prevalence, though, is unknown, mainly due to the fact that there's an inherent bias among clinicians regarding endometriosis existing in anyone other than white females of reproductive age, which was clearly stated in textbooks until the late 80s in textbooks in gynecology. Other groups have been found to have endometriosis, including adolescents, postmenopausal people, people of color, and transgender males. There are actual studies looking at transgender males and the rate of endometriosis. There's other factors, including the recognition of endometriosis is inadequate, and the diagnosis time ranges from 4 to 11 years, with 65% of people being misdiagnosed initially. And some, we don't know how many, because they were never diagnosed. So what is the etiology? We don't really know the exact etiology. There have been many theories presented, but it's becoming more and more evident that physiologic, genetic, environmental factors, and immunologic dysfunction play large roles in the etiology. Now, we used to think that endometriosis was a disease limited to the pelvis. It is not. It is a systemic disease. There was a review in The Lancet by Hugh Taylor at Yale School of Medicine. Endometriosis is now considered a systemic disease rather than a disease predominantly affecting the pelvis. This review has illuminated the fact that we've discovered that endometriosis affects metabolism in the liver, leads to systemic inflammation, and alters gene expression in the brain, leading to pain, hypersensitization, and mood disorders, which are both very common in affected patients. There's some key factors that are important in the systemic presence of the disease. There's pro-inflammatory cytokines and shifts in circulating immune cell populations that cause inflammation outside of the pelvis. Circulating microRNAs have been found in abundance, and these can locally modulate gene expression throughout the body. Data from animal models show that cells from endometriotic lesions can migrate into other organs, including lungs, liver, spleen, and brain. And I've actually seen endometriosis in the lungs. A different department were doing a biopsy of a mass in the lung of a 35-year-old female, and it turned out to be endometriosis, an endometrioma, and I was consulted on it. This was a few years ago. Patients with endometriosis have been shown to have alterations, in cardiovascular, neurological, metabolic, and immune function. For example, an analysis of the Nurses' Health Study 2, done between 1998 and 2009, showed that women with surgically confirmed endometriosis had a statistically significant greater risk of cardiovascular disease than women without endometriosis. Endometriosis is a disease that is a disease of contrast, is the way I like to put it. It's benign, but it is invasive and can have distant metastasis. We've really just begun to discover the extent or scope of this disease. Now here's another study. This is pretty recent, actually. It was published in November of last year, in which it's a study that suggests another possible contributing factor to the etiology or part of the pathophysiology or the result of endometriosis. And it looked at the endocannabinoid system and the microbiome and how it can influence endometriosis. The endocannabinoid system regulating inflammation and pain perception, and the microbiome influencing immune responses and hormonal balance. An unhealthy gut, now this is really important because actually I've run into this clinically more often than you would think. An unhealthy gut called dysbiosis can create an enzyme called beta-glucuronidase, and beta-glucuronidase reactivates estradiol and causes it to recirculate, mimicking higher estrogen levels, making women seem like they're estrogen dominant when they really aren't. It's just recirculating of the estrogen. There's evidence that a dysregulation of the endocannabinoid system and the gut influence endometriosis symptoms and progression via changes in CB1 receptor expression and changes in circulating levels of the endocannabinoids. More research is definitely needed. What are the symptoms of endometriosis? Well, dysmenorrhea is the most common symptom. It affects at least 70% of the patients, but this is progressive and worsening dysmenorrhea and pain at non-menstrual times of the month rather than the common menstrual cramps. Infertility is also very, very important. In fact, many patients aren't diagnosed with endometriosis until they undergo infertility evaluations. Approximately up to 50% of women with infertility are diagnosed with endometriosis. Then there's something called endobelly, which actually relates to the gut dysbiosis that is part of the process. But endobelly is bloating, constipation, diarrhea, and really can be quite disruptive. So endometriosis really significantly affects the patient's physiological, mental, and psychological health, and their social and economic participation. Many patients are on antidepressants, anti-anxiety, and even antipsychotic meds. If you go from doctor to doctor complaining of pain and everyone tells you there's nothing wrong, you will be on antipsychotics too. It also significantly affects the families, partners, and carers of patients with these diseases. What are the treatment options? Well, that's a problem. The main factors to consider in treatment is how severe the signs and symptoms are and whether or not the patient wants to become pregnant. Medical and surgical interventions are comparable, cause comparable pain relief, 44% pain recurrence after medical treatment and 53% pain recurrence after surgical treatment. Conventional treatment is mediocre at best, and there's insufficient evidence on the efficacy of any specific medication for relieving pain associated with endometriosis. So the best treatment for endometriosis is something that will relieve the pain, treat the other symptoms of endometriosis, and not adversely affect fertility. This is where cannabis can be an effective treatment and far superior to what we even have now. So, potential for cannabis. Well, we'll start with the endocannabinoid system, the master regulator of the body, using Dr. Russo's term. Specifically, we're going to talk about the theory of clinical endocannabinoid deficiency, which suggests that in some cases the body doesn't produce enough endocannabinoids or enough receptors for the endocannabinoid system to function. As a result, it means the many functions in which the endocannabinoid system is involved aren't regulated properly. It was proposed by Dr. Ethan Russo in 2008 and then reconsidered in 2016. You may think after these next couple slides that I'm here just really lauding Dr. Russo with a lot of praise, but he deserves it. It's just that these happen to be quite important in talking about endometriosis. There are 4 tenets to conditions to qualify as a clinical endocannabinoid deficiency condition. The first is an increased sensitivity to pain called hyperalgesia. Now, people with endometriosis are commonly hypersensitive to pain due to central pain sensitization. The microRNAs lead to changes in the electrophysiologic activity and the gene expression in the regions of the brain associated with pain perception. That seems to be the cause, as illuminated by Taylor et al. In 2021. Secondly, all the conditions are usually diagnosed subjectively by a process of exclusion, there being no objective tissue or lab findings diagnostic for any one of them. Endometriosis does not have a pathognomonic signs or symptom that are specific for the disease. Mainly, the disease has symptoms that are common to other GYN or even some non-GYN disorders such as fibromyalgia. Third, all are associated with a higher instance of anxiety and depression. Again, probably via the microRNAs causing changes in the electrophysical activity and gene expression in the regions of the brain associated with anxiety and depression, as mentioned earlier. And finally, number 4, these conditions often overlap with some combination of similar conditions, such as PTSD, MS, autism, etc. I'm just at this point going through a few scientific studies that show the potential for cannabis being a treatment for endometriosis. This next study, Dr. Russo, 2011, Taming THC. It's probably a paper most of you have read, if not should read, because it really is very important. It's a review that explored the cannabis terpenoids and focused on phytocannabinoid-terpenoid interactions that could produce synergy with respect to treatment of pain, inflammation, depression, and anxiety. Those 4 symptoms that mentioned are components of endometriosis. A few earlier studies demonstrated, and Dr. Russo talked about this a little earlier, that GPR18 stimulation was found to cause migration of cells. Then a couple of years later, this was shown to cause migration of endometrial cells. Well, CBD is a GPR antagonist. It can stop the migration, well, potentially, can stop the migration of endometrial cells, making a potential prevention and treatment of endometriosis. This next study was a clinical study in persons with and without chronic pelvic pain. They had 49 people. 49 people underwent with endometriosis confirmed, underwent laparoscopy again. 28 had chronic pelvic pain, 21 did not. Samples were taken from the peritoneum of both, and it revealed that the people with chronic pelvic pain had more TRPV1 immunoreactivity when compared to the people without chronic pelvic pain. The study showed that TRPV1 expression in peritoneal endometrious foci is related to chronic pelvic pain. And a subsequent study found that CBD stimulates and desensitizes TRPV1, leading to less pain. This next was a review study looking directly at CBD for the management of endometriosis and chronic pelvic pain. Most of the studies in this review are preclinical. These studies have shown that CBD decreases the secretion of pro-inflammatory cytokines, including interleukin-6 and tumor necrosis factor alpha, and can increase the levels of anti-inflammatory cytokines. Also, the anxiolytic, antidepressant, neuroprotective, and mood-stabilizing and sleep-modulating effects of cannabinoids in general may be very useful in the management of the non-physical symptoms frequent among patients with endometriosis. Now, we can't leave THC out completely. So, this next study was a mouse model was created by a group of researchers to mimic some of the conditions in human endometriosis. These include pelvic pain, anxiety, and cognitive deficits. The mice were treated with 2 milligrams per kilo of delta-9 THC daily for 28 days. The THC was given via subcutaneous injections. Now, that's not how we ingest THC, but keep following. The mice were treated, and they found that THC reduced pelvic pain and cognitive impairments in the mice, but it had no effect on their anxious behavior. Remember, they were only using THC. THC may also seem to inhibit the growth and development of the endometriotic implants. Now remember, as many have said, preclinical studies may not translate to the human experience, but this is important information. Here's a picture of the pre-THC treatment and post-THC treatment of the endometriotic implant, of one of them. Now, since we like to use whole plant artesian formulas, we can't leave the terpenes out. Beta-caryophyllene causes regression of endometrial implants in a rat model. This study looked at beta-caryophyllene, and again, they used adult female rats and mimicked endometriosis. Fragments of the endometrium were implanted in the peritoneal cavity of the adult rats. They watched them grow over a 4-week period, and then treatment started with beta-caryophyllene 10 milligrams per kilo. They also used 30 milligrams per kilo for 21 days, and the growth of the endometriotic implants were measured again. There was also a control group. The beta-caryophyllene 10 milligrams per kilo suppressed the growth of endometriotic implants by 52.5%. The 30 milligram per kilo did not do as well. It was only about 30%. Beta-caryophyllene, that follows along with less is more. Beta-caryophyllene also produced apoptosis, more cell death, and also, just as important, There was no statistically significant difference observed in the fertility of the rats that were treated with beta-carophylline and that were not in terms of fertility. That's really what you want in treating endometriosis. You don't want to interfere with fertility because that really does guide treatment. So beta-carophylline was an effective putative treatment. Now let's summarize some of this data because I'm moving along here. GPR18 may play a role in cellular migration. It appears to specifically induce endometrial migration. CBD is a GPR18 antagonist. TRPV1 is related to chronic pelvic pain in women. CBD stimulates and desensitizes TRPV1. Endometriosis appears to be associated with a downregulation of CB1 and CB2 receptors and upregulation of TRPV1. Endometriosis also appears to be associated, cannabinoid agonists can potentially inhibit endometriotic cell proliferation. THC and beta-carophylline seem to be effective putative agents. Please note that whole plant cannabis can reduce pain by interacting with a wide range of cannabinoid, opioid, vanilloid, serotonergic, and anti-inflammatory receptors, as the illustrious Dustin Sulak pointed out in a few of his talks. People with endometriosis are using cannabis and finding relief, so we need to pay attention to that. Oh, and I do have time to do the case study. Awesome. This is a, well, I have on my notes 44, but 42 on the slide. She was in her 40s, early 40s, diagnosed with endometriosis who had a long history of chronic pelvic pain, pain with intercourse, and anxiety and depression. And she had been going along for a few years. She went through medical and surgical interventions and really did well for a short period of time. But when she entered her 40s, things worsened. She started to develop sleep issues, moodiness, and increasing pelvic pain and pain with intercourse. And it was really starting to impact her marriage. We checked her hormone levels because women in their 40s are usually perimenopausal or certainly almost there. Women start to lose progesterone first. And the main reason is as the ovaries start to decrease their production of hormones, testosterone also comes from not just the ovaries, but it also comes from the adrenal glands and can be produced from DHEA. Estradiol also is not just produced in the ovaries, it's produced in fat cells and is produced by the adrenal gland. Progesterone only comes from the ovaries, so when the ovaries start to decline in function, progesterone is the first hormone to decrease. And that makes a woman estrogen dominant. So it can certainly reactivate, so to speak, the endometrial implants. We added progesterone to her regimen initially, and this helped her with sleep and mood stabilization, but it didn't help with the endometriosis. Now, in most patients, or I should say many patients, maybe 2/3 of patients, progesterone does really offer a tremendous help because it balances out the effects of estrogen. But 1/3 of patients with endometriosis are progesterone resistant. Unknown etiology of that also, abnormal progesterone signaling, chronic inflammation, aberrant gene expression, all can be causes. But progesterone resistance leads to, you can't counteract the effects, the estrogen dominance going on. So one of the things we did is we implemented a healthier lifestyle, modified her diet, and she lost 20 pounds over time. Why is weight loss important? It's important because in the management of patients is because fat cells contain estrogen. The more fat cells you have around, the more estrogen you have, and also adipose tissue causes chronic inflammation as well. So maintaining a good weight is also very important. We counsel patients about eating in our office. We counsel patients about eating real food, following an anti-inflammatory diet, avoiding toxins, chemicals, artificial sweeteners, etc. Things actually we all should be doing. We also encourage foods that can encourage the healthy metabolism of estrogen, because that's very important as well. These foods are actually the cruciferous vegetables. They contain a product called 3,3-diindolylmethane, which has been shown to enhance the healthy metabolism of estrogen as opposed to allowing it to recirculate. This group of vegetables includes kale, cauliflower, broccoli, Brussels sprouts, and arugula. The vegetables that cause gas, bloating. Just to warn you, it's not easy to eat a lot of that. We also encourage exercise. Exercise can decrease the intensity of cramps because exercise increases anandamide levels, which can lead to calming, relief of pain, and certainly improved mood. Yoga in particular has specific poses and stretches for the relief of dysmenorrhea. Tai Chi is another. The exercises that have spiritual components, energy components to them, are very, very effective in managing some symptoms of endometriosis. We then titrated the patient to a type 3 CBD dominant tincture, 10 to 15 milligrams once or twice a day, depending on symptoms. She also vaporized with type 1 flower. On my slide, you'll see a 6+ to 1 to 3 tincture. That is not CBD dominant. That 6 should be 10+, always. Then it'll be CBD dominant. We she used a vaporized with a type 1 flower for breakthrough pain and for sleep. The addition of, and this is the part that was really very helpful, the addition of a type 1 or type 2 vaginal suppository really helped to significantly improve the pelvic pain and allowed her to have intercourse. Suppositories are hard to find, and hopefully companies are coming out with some suppositories with a shelf life and are effective and can have a lot of the aspects of the plant in them. Right now I have patients make their own, and it can be difficult and cumbersome, but patients with endometriosis are determined to relieve their pain. Cannabis teas, as Dustin mentioned, are also very helpful because you can get THCA, put a little bud in the water. THCA will stay THCA because the water isn't hot enough to lead to decarboxylation. This patient is now productive in her vocation, has an improved quality of life, and has a healthy sex life with her husband. In fact, he sent me flowers saying thank you. This was really life-changing for this patient. Now, to summarize, and I'm running on time, yes. Cannabis has been used throughout history to treat conditions in people assigned female at birth. Just read Dr. Russo's History of Cannabis in OBGYN, a historical review. It's an excellent, excellent paper. Endometriosis is a debilitating disease. It affects patients in all aspects of their life, including their families. Become familiar with the theory of clinical endocannabinoid deficiency. It's a theory, but it certainly can be a helpful guide in your management, or certainly in thinking of what to do in certain conditions. Whole plant cannabis should be considered as an option in a holistic program. Be willing to use different modes of delivery for the same patient, and I did not know Dustin, speaking before me, was going to say what I just said. People with endometriosis are using cannabis, and many are getting the relief they have long sought. Conventional treatment is mediocre at best, and why not try cannabis? Thank you. I don't think I have time for questions, but I will be here all day today. Thank you.